Good evening, and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus, and a family medicine physician with Gateway Family Health Clinic in Moose Lake. I'm your host for our program tonight on eye problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to the station. The telephone numbers can be found at the bottom of your screen. Our panelists for this evening include Dr. Todd Brittain, an ophthalmologist with Relf EyeCare Specialists in Hermantown, and Dr. Kevin Treacy, an ophthalmologist with St. Luke's Eye Care Medical Arts Building. Our medical students answering the phone tonight are Michael Gutman from Marshall, Minnesota, Tanner Nordseth from Round Lake, Minnesota, and Lucas Rademacher from Battle Lake, Minnesota. And now on to tonight's program on eye problems. Gentlemen, welcome. This is our last show of the season. It was nice of you to come out. Dr. Treacy, I think we'd like to start with you. Tell me a little bit about your practice before we jump into what we're doing.
All right. I have been practicing ophthalmology in Duluth since 1988 and practice primarily at the Medical Arts Building and do surgery at St. Luke's and Two Harbors and Moose Lake, or actually Cloquet now. So I've enjoyed practicing in the north.
Good for you. Nice to have you. Dr. Brittain, yourself, how long have you been around?
Yeah, I'm a comprehensive ophthalmologist. I've been practicing in Duluth for 3 years now. Prior to that, I was in Michigan for 3 years as well.
So what does comprehensive mean?
Comprehensive means a little bit of everything, but
so GP, kind of like?
Exactly, like GP for the eye. So
very good.
Yeah.
Dr. Treacy, we're going to start tonight with some anatomy. You've got the model sitting there, so have at it.
Sure. Well, the eye is an amazing structure. It's not very big, but it's got all sorts of connections and functions that we think about every day when we're evaluating people that are having trouble with vision. The goal is for people to have incoming light go through the front part of the eye and become focused on the back part of the eye, the retina. And some people can do that without glasses. Other people need glasses to bring it into focus. And then from the retina, these electrical signals that are generated are sent back to the brain to be interpreted as the vision that we enjoy. And there's about 1.2 million nerve fibers that connect the eye to the brain. And our goal is to protect those nerves for a lifetime, as well as the other structures in the eye.
Dr. Brittain, it raises a question to me, why do we need glasses? So we've got the cornea, we've got the lens, and that focuses back. So why do we use glasses? What's the reason for that?
So glasses are used for a number of reasons. Oftentimes when we are, let's say, nearsighted, so a nearsighted person, either their eye is either too strong or it's too long, and glasses do the, essentially, weaken the eye to some extent to focus light on the back of the eye, on the retina. Patients who are farsighted, although it sounds like they can see far, not necessarily true. Everything's a little bit blurry, and their images tend to focus behind the retina, and so the glasses act to bring the image on the retina. Glasses are all about focusing the image on the retina where it should be. And then the other reason a lot of us start to wear glasses when we get into our mid-40s is because of what's called presbyopia. Our lens starts to harden, it just doesn't change shape like it used to, and that makes it tough to see things up close. When we're younger, when we're in our 20s, the lens balls up into a ball, and that allows us to see up close, but we lose that ability. Like the rest of our body, our lens becomes less flexible as we get older.
And pres to me means old or aging or whatever. So there's several ways that you can fix that vision. One is with the lenses. Kevin, are there other mechanisms that we can use for improving vision? Short of having to wear the glasses.
Right. Yes, basically, if a person needs help, either bringing the light rays farther back or closer in, different types of lenses can do it. Glasses have been around for centuries. Contact lenses are a nice way to also correct for refractive error that sit right on the cornea, and they can provide the same function. The cornea can be reshaped, so tissue can be taken away in a certain pattern that will allow the light rays to fall on the back of the eye. So that would be Lasik or PRK. And now with, for instance, cataract surgery, taking out the cataract not only will improve the sharpness of vision, but it can also eliminate the refractive error more and more. So all of those methods can help.
And I assume that you gentlemen both do Lasik surgery, or are involved with you do the LASIK. So what do you do with Lasik surgery, Todd?
Yeah, our clinic does do Lasik surgery. So Lasik surgery, I think the best way to explain it is to explain it in the form of an analogy. So when we do Lasik surgery, you want to think of the, can I borrow your monitor?
Mm-hmm.
So with Lasik surgery, it's essentially performing surgery on the cornea, which is the clear part of the eye. Think of the cornea like a book, a book with many pages. With Lasik surgery, you're essentially opening up that book or opening up the cornea, and you're removing or altering, pages within that book, and then you're closing the book. So you create a flap. You lift that flap and you laser the cornea underneath the flap. And then when you're done, you put that flap back. The advantage of doing LASIK is almost immediate improvement without a whole lot of discomfort, after the procedure. There is another, did you want me to talk about any of the other procedures?
Oh, go ahead.
Okay. So another procedure.
When we think you're taking too much time, I'll move it back to Kevin.
Give me the hook. So there's another procedure called PRK, which in contrast to LASIK does not create a flap. PRK, what is done is you essentially...
What does that stand for?
Yeah, Photorefractive Keratectomy.
Okay.
Mm-hmm. And so with PRK, what you're doing is you're removing a layer, the most superficial layer of the cornea, and then you're lasering that cornea. The drawbacks of PRK is, of course, you're causing a large abrasion on the surface of the eye, which is uncomfortable. The healing takes longer. The advantage is you're not cutting a flap, so you're not cutting through nerves. One thing that some of our LASIK patients notice is that dry eye can be more problematic after LASIK surgery. PRK is less likely to cause some of those issues. And you also don't have to have as thick of a cornea for PRK as you do for LASIK, because you're not creating that flap.
Thank you. So Kevin, why don't you take us into the lens? So let's talk about cataracts a little bit.
All right.
When, why, and how often should they be done together? How do you do these things? So when do you determine that you should do cataract surgery? Let's start there.
Sure. Well, I'm going to show this again.
We should let you guys sit together.
Yeah. Well, we'll keep our distance. This model has a clear lens, and we start life with a clear lens. As we get older, that lens becomes cloudy, and when it starts to interfere with visual function, trouble with reading, driving, depth perception, handiwork, whatever it might be, then it's reasonable to offer cataract surgery, which involves going into the eye, taking out the cloudy lens, and then putting a clear lens, plastic, synthetic material, in the same place where the cataract was. And by doing that, again, as I mentioned earlier, not only can you clear the vision, but you can redirect the light rays and hopefully bring them into focus. Some people want to be left nearsighted so they can read without glasses. Other people want to do the computer without glasses. Other people want to do good distance vision. And so it's a discussion that the surgeon and the patient have. What type lens? There are some that give more than one focal point, and there's drawbacks and whatnot. So it's actually gotten more involve the decision making because we have so many options now.
Let's have a little discussion on that, because one of the questions was having the cataract surgery, and what are the options for lenses and what should they consider? And I know that some patients set up for distance and near and all these, and then there's panoptics and some other types of things. So Todd, it's your turn if you want to jump in, and you guys can talk back and forth if you'd like.
Yeah, we could spend the rest of today's show talking about different lenses, and it seems like there's always something new coming out. Essentially, when deciding what lens to select, a lot of it comes down to whether you want to be free of glasses for some situations, all situations. The lens, what we call monofocal lens, this is the lens that's often covered by most insurance companies, allows us to correct the vision for, essentially one distance. If we take into account that all of us basically have three distances where we kind of go about our day-to-day, activities. There's the way off in the distance, being able to see across the room. There's computer distance, and then there's reading. With a monofocal lens, we can correct for one of those distances without glasses, and then you wear glasses for the other two. There are lenses that give you much more broader range of vision that allow you to see everything from distance to reading without glasses. And they work quite well in most circumstances. They don't necessarily free you from glasses all the time, but they do give you some spectacle independence for most situations.
What is panoptics? Kevin, do you?
We consider that to be a trifocal lens where it's basically got distance, intermediate, and near. And the earlier versions were rather problematic because they were notorious for creating glare and halos with nighttime driving, and some people, that became a real detriment to those implants. There's an out-of-pocket cost associated with these implants. But again, the quality of the multifocals, trifocal, bifocals have gotten better, and there are some that blend vision a little, I guess, more naturally. So basically, panoptics is one of many options.
And once they're in, you have to live with them. So big choice ahead of time.
We like you to live with them.
Yep.
They can be removed and replaced, but every time you do that, you run the risk of complications where...
Dry eyes. Todd, you want to talk about dry eyes a little bit?
Yeah, dry eye is something I think a lot of us deal with. I would say, it's roughly 80% of my patients that I see day in and day out have some symptoms associated with dry eye. What's often confusing with dry eye is your eyes often water when they're dry. So it's kind of the eye's last-ditch effort to try to moisturize itself. There are a lot of things that factor into dryness. Our environment that we live in, especially here in Duluth, the cold, dry weather. Winter is the worst time for dryness. Different medications that we take, a lot of the side effects of those medications are dry eye. And then just getting older, our bodies don't work quite as well as they used to.
What are some remedies that you guys prescribe, Kevin?
Probably the most common is recommending over-the-counter lubricating drops. And those, for mild dry eye, seem to be adequate for many people. We've learned that it's not always a decrease in tear production, but there can be an increased evaporation. So helping the glands secrete oils onto the tear film to reduce evaporation is another approach that is often discussed with patients if they show signs of needing that. And now there are prescription medications to suppress inflammation and also stimulate tear production, and even novel techniques of stimulating nerves within the nose to increase production of tears in the eye. Ooh. So a lot of research going in because, as Dr. Brittain mentioned, it's a common problem.
We forget that the great American desert is the northern latitudes in the wintertime, and the humidity is usually very low. Macular degeneration. Dr. Treacy, you have the equipment over there. Do you want to address macular degeneration a little bit for us?
Yeah, and I think for this, I'll take the model off and show the picture because, again, light comes in the front, goes through the cornea, goes to the lens in the back of the eye, and then just off the optic nerve is called the macula, and that's where the cones and the density of the nerve fibers are greatest, and that allows for the fine detail that we need for reading small print and other items. Well, as we get older, that area of the retina is prone to degeneration and accumulation of material that can cause worsening vision. Most of it is dry, meaning there's no new blood vessels. Occasionally, part of the response of the eye to this degeneration is to develop new blood vessels, and that can lead to severe vision loss due to scar tissue. So there are nutritional recommendations, dietary supplements that can help slow down the degeneration, trying to prevent severe vision loss. And if people do show new blood vessels, then injecting medicine in the eye can also help maintain good vision.
So the difference between dry and wet is the blood vessels.
Mm-hmm.
So do you brought up one of the questions is what should I take? Are there vitamins or are there things I should take to protect my eyes?
Well, I think there's many good reasons to maintain a well-balanced diet. Lots of fruits and vegetables, green leafy vegetables in particular may reduce macular degeneration. If people develop what we would consider intermediate or advanced changes on their eye exam, even though they're not aware that they have a problem, then we do recommend some over-the-counter nutritional supplements that have a combination of vitamins and minerals.
Todd, there's been a couple of questions on eye health. We're addressing it a little bit here, but someone's got normal vision, never had any problems. Why should they see an ophthalmologist?
Yeah, a lot of the
or an optometrist, I guess, for that sake too.
Yeah, absolutely. Unfortunately, a lot of eye conditions, they have a very insidious onset, and we think of things like glaucoma.
What is glaucoma?
Yeah, glaucoma is damage to the nerve in the back of the eye, and has many factors that play a role in terms of increasing your risk of developing glaucoma. Age is certainly a risk factor, family history, eye pressure. The thing is that a lot of the changes that happen with glaucoma they go unnoticed until the glaucoma is very bad. Glaucoma is something where you're not going to notice the changes in your vision without specific testing, which we can do in the office.
Dr. Treacy, diabetic eye exams, how often should they come in and what are you looking for?
Well, generally we recommend type 1, the younger onset, within 5 years of the diagnosis. Type 2, the older onset, probably should get an eye exam shortly after the diagnosis. The idea is to establish a baseline exam and then monitor to detect changes that need treatment. And it can be a slow process before diabetic changes occur in the back of the eye. So annual exams is still the current recommendation. And if we start to see leaky blood vessels, new blood vessels, then the frequency may go anywhere from 3 to 6 months, 8 months.
I think we've learned a lot here in just the last few minutes about you can have very normal eyes, but you don't know about glaucoma, and there's insidious changes that can take place in vision, macular degeneration, some of the other things that you may not notice. So I think it's a really good idea to go in and get checked. Floaters. Dr. Brittain, it's your turn. There's some questions on floaters. What are they and how can I get rid of them?
Yeah, so floaters, just a general term that we often use, but when we're referring to the typical floaters that most people deal with, what we're referring to is the vitreous in the eye or the jelly that's in the eye. It starts to liquefy and pull away from the back of the eye. This can happen for a number of reasons. Trauma, I'd say the most common is, again, not to not to keep bringing this up as an excuse for things, but getting older. As we get older, that jelly starts to shrink and liquefy and pull away from the back of the eye. Floaters are a nuisance for the most part, but we do like to do an exam when you first develop a floater, because there is a small risk of developing a retinal tear, retinal detachment with a new floater.
Dr. Treacy, a wrinkle in the retina.
Mm-hmm.
What's that all about?
That typically refers to a condition called epiretinal membrane, and that often results, again, related to vitreous changes. As we get older, the jelly becomes more liquid. It can shift around. It can actually separate from where it used to be attached to the back of the eye. And as it separates, it can cause little breaks in the inner surface of the retina that allow cells to grow out and spread across the macula, which we talked about for macular degeneration. It doesn't cause new blood vessels, but it can distort the blood vessels and the retinal photoreceptors. So people can notice a straight line appearing wavy or distorted, and surgery can be done, but many times that's not necessary.
Fuchs syndrome, F-U-C-H. I don't know that one.
Mm-hmm.
What is that?
Yeah, so Fuchs involves the cornea, which is the clear part of the eye, like the cornea is like the glass on the watch. With Fuchs, the cells that are responsible for pumping fluid out of that cornea and keeping it absolutely clear, they don't work quite as well as they should. Patients with Fuchs, they can have a couple symptoms. I'd say a lot of patients will have more increased trouble with glare. When we look at a patient with Fuchs under the microscope, we actually see these bumps on the backside of their cornea, and those bumps tend to catch the light and cause issues with glare. We worry about our Fuchs patients more when we're planning for cataract surgery, because it is an increased risk for complications with cataract surgery. One other symptom that Fuchs patients may notice is blurry vision when they wake up in the morning, when that cornea is more edematous or more swollen, and this blurry vision tends to improve as they go on throughout the day. Treatment for Fuchs can involve things like salt water solution drops or ointments, or in the event that it should worsen, the corneal transplant, which has come a long way over the years in terms of correcting the condition.
There's another whole subject, but I don't think we have time for that. Glaucoma and treatment, Kevin.
Sure. We touched on it earlier, but again, 1.2 million nerve fibers bringing both your central vision and your peripheral side vision to the back, to the brain. And it's called the silent thief, because you can start to lose those fibers, develop subtle loss of peripheral vision, and ultimately it can progress to take away not only your side vision, but your central vision. So the one thing we have to treat it is to lower the pressure. And there are people with normal pressures that need low normal pressures. So it really depends on how a given eye is responding to a given pressure. There are people with high pressure that never develop glaucoma. So that's where the eye exam, looking at the nerve, helps us decide when to treat.
This lady, both she and her husband have family histories of cataracts and macular degeneration. What are the chances that the children will have these conditions? Is there something genetic here or not? I don't know. So either one of you.
Yes, certainly there is a genetic relationship to macular degeneration, but there are a lot of factors that come into play with macular degeneration. Things such as smoking, which is something we counsel all our patients on. If you can stop smoking, it's definitely in your best interest. Other things such as, again, age, macular degeneration and cataracts are more prevalent as we age. And things like sun exposure, these are things, you think about, what are things that I can alter in terms of lowering my risk of going on to developing these conditions. Protecting yourself from the sun with sunglasses is something that you can do. But to answer the question, there's not a definite risk to your children that they will develop these conditions. There are a lot of factors that come into play.
Shingles, herpes zoster in the eye. We don't have a lot of time, but I think we need to talk about it a little bit, and it's one of the reasons to get the Shingrix shot.
Very much so. It's unfortunate that so many people that do develop shingles, which can involve the face, typically there's a line right down the middle of the forehead, the eyelids, and it can lead to scarring of the cornea, inflammation inside the eye. So certainly prevention is better than treatment because frankly the treatments don't always work. And the Shingrix vaccine, I recommend everyone that is eligible receive it.
It's like a terribly bad pine needle tear on your eye that just doesn't go away for a while.
Mm-hmm.
Blue light, Todd, does blue light affect your eyes, and should I have light filters on my glasses?
So blue light, I think it's gained a lot of attention. As far as its damaging effects on the eye, it does not have any damaging effects on the eye. I think at best it can disrupt your night's sleep, but.
Thank you. Gentlemen, thank you very much. A great discussion tonight. We could go on and on. I want to thank our panelists, Dr. Todd Brittain and Dr. Kevin Treacy, and our medical students volunteers, Michael Gutman, Tanner Nordseth, and Lucas Radermacher. This is our final show of the season. Our thanks to all of the doctors and phone volunteers who have been with us throughout the season for Doctors on Call. I hope you have enjoyed these programs, and thank you for watching. I want to thank the staff here at WDSE, and I also want to take a shout out to Linda Liskowitz, who has put together the panels, made sure we had all the help that we need for this. Thank you so much.